7:30. So Gretchen and her team are going to present a lecture today on the withdrawal of advanced respiratory support, but goes beyond just that and really brings in the whole interdisciplinary aspect. So Gretchen, I'll pass it off to you.
All right, thank you, everybody. If you have any sound issues or can't hear for any reason, please let us pause and make any adjustments we need to. So I'm really excited today to talk about the withdrawal of advanced respiratory support and the approach to the symptom management aspect, as well as the robust interdisciplinary support. So in order to do that well, I bring in some of my colleagues, and with me today, I have Carissa Skeideman, who is one of our inpatient hospice nurses. I have Carrie Fulkerson, one of our inpatient hospice social workers, Dan Flug, one of our chaplains on our team, and Kayla Conklin, who is a music therapist at our institution. So we have no disclosures. Some objectives today, we'll be discussing the preparation for withdrawal of respiratory support, as well as acute symptom management. We will review the pharmacology of medications commonly used during withdrawal of respiratory support, including the evidence-based approach to bolus dosing of opioids and infusion titration, as well as some other medications. We'll define the Respiratory Distress Observation Scale, RDOS scale, in clinical application, and discuss the involvement of the interdisciplinary team during the process of withdrawal of respiratory support. So some key components of this whole entire process is having protocolized approaches to withdrawal of life-sustaining treatments and symptom management, have clear and compassionate communication and shared decision-making, an exploration and support of cultural, spiritual, and family traditions. I thought it's fitting as we this week are remembering and honoring Jesse Jackson to share a quote that was shared by Dan, one of our chaplains here, speaking with us today during one of our morning huddles. And so I've reflected on this a lot this week as we think of that exploration of the cultural and spiritual and family tradition aspect. So I'll read that quote. "America is not like a blanket, one piece of unbroken cloth. America is more like a quilt. Many patches, many pieces, many colors, many sizes, all woven together by a common thread." So think of that picture of the quilt and that quote as we think about our holistic approach to withdrawing from respiratory support. So the way I usually start is to talk about the history of sort of prior practice or previous practice to best practice, because there are some institutions that are still continuing some of the older practices that I think we as hospice and palliative physicians are part of the process of helping things move from that practice to best practice. So you may find wherever you work that there could be a mix or one side of this figure or another, but just we'll talk so where things happen. And I'll even speak, this is where our institution was 8 years ago on that left box. So in previous practice, we had more lack of protocols or guidelines. There was so much variation in patient care depending on individual or local practice or customs or experiences. And we found that that led to the titration of opioid infusions with literally, there was a comment section that said titrate to comfort, and it was nurse-led. The opioid infusions often were titrated every 60 minutes, increased. Comfort care was the order set, they really even weren't order sets, or if they did have them, they didn't have clear guidelines. The bolus doses were every 30 or 60 minutes for acute breakthrough symptoms, but honestly, it was the infusion that the nurses were increasing to maintain comfort. There ended up being rapid titration of opioid infusions, which increased the risk of opioid toxicity and opioid-induced hyperalgesia. So between 2018 and 19, we modified our comfort care order set and medication policies just based on some things I had been learning and just really felt convicted we need to adjust to best practice. And this led to very much a change from nurse-led going up on infusions to provider-based orders and protocols And it was a huge culture change, a lot more than we anticipated, but we worked through that. And here now, 7 years later, we are in a much different place with more standardized practice. So I'll share a lot of what we do here during this lecture. So in the best practice, based on, and this is evidence-based in literature, comfort care order sets with an evidence-based approach are recommended. Having infusions ordered and managed by providers, physicians, APPs, bolus dosing every 10 to 15 minutes for acute breakthrough symptoms, and opiate infusions that are titrated if needed after reaching a steady state, which is 8 hours in most cases. And then having that interdisciplinary approach of supporting the cultural, spiritual values of patients and families and the goal of equity and end-of-life care. So we'll start with medical management and talking about the pharmacology of opioids. So, and some key points is that opioid infusions should be titrated once steady state is reached. So given the half-life of opioids and knowing the half-life is multiplying that by 4 to 5 equals a steady state, in general, takes about 8 hours for an opioid infusion to reach a steady state. So appropriate dosing and titration of that bolus dosing that as needed opioid is critical for that immediate symptom relief while waiting for the infusion to reach the steady state. So I like to use the analogy of thinking of your infusion like a long-acting opioid. So if we're going to start a patient on a long-acting opioid, an oral, let's say opioid, we first calculate how much of that PRN medication are they using so that we can figure out the right dose. And once we start a patient on that calculated dose, we wait till it reaches steady state before we go up on it further. So if with the old way of practice, if we were increasing those opioid infusions every hour, did some of the math of this, that would be like titrating our patient's long-acting morphine pill every 6 hours and going up because it wasn't working, so keep going up. So that leads to dose stacking. So as a philosophy, think of the titration of your opioid infusions similar to how you titrate your long-acting opioids. And sort of our opinion here is that it could be, there's a way to do it as a calculated approach that can best estimate the patient's needs. So this was an article that I found helpful that gives just general overview of different practices and considerations. So there's not a lot of evidence about palliative extubations, despite the prevalence of that and impact on families. And so there's a lot of limited literature, but there's getting more and more over the last 5 or so years. So it acknowledges there's highly variable practices. There's a fear of deliberately hastening death that can lead to undertreatment of symptoms, but also without any standard protocols, it can lead to overtreatment of symptoms as well. So this article talks about planning, communication, symptom management, and then gives just a general idea of what some other institutions are using as protocols. So I'm just going to summarize some of the things that I found in this article and one other that I referenced before, as far as like what are other institutions doing. And even with these, you can see it's still a little bit vague, and it's not as calculated as I would have liked. So for example, some of the things that are mentioned in the article is that you could start a continuous infusion at 50% or half of the bolus dose. And then initial infusion rate could be based on the response, which again, a little bit vague. If a patient receives a couple boluses in an hour, you can increase the infusion by 50 to 100%, depending on their level of comfort. I talked about that steady state you want to wait for the infusion to reach. And then for bolus dosing, that bolus first approach, totally agree with that. That's really important. Again, bolus dosing could be 1 or 2 times the hourly infusion. They mentioned if someone's opioid naive, you may start for coming off of respiratory support, a bolus dose anywhere between 2 and 10 is within a standard practice. Could be more if they are not opioid naive. And it's common practice to administer a bolus dose prior to starting infusion or titrating the infusion. And then there's recommendations for having specific instructions and order sets for the medications of what symptoms it should be addressing. And then considering longer dosing intervals with liver disease. there's more and more talk about application and adding this respiratory distress observation scale, which we'll talk about, that gives a more objective measure of dyspnea for patients who can't self-report. So we're not just thinking, oh, I think we should give more medicine or more opioids for dyspnea. It's really you really having an objective measure to go by. Some other medications mentioned in this article is midazolam, using that as a benzodiazepine adjunct. And it's similar to the opioid. Some institutions are, if patients are receiving a continuous infusion, they can receive a bolus dose of 1 or 2 times that hourly rate of the midazolam infusion, and boluses every 5 or 10 minutes. And if you receive a couple boluses in an hour, it's reasonable to double or increase the infusion rate. Many of our patients in the ICU are on a combination of fentanyl and propofol prior to getting the palliative or hospice team involved. And propofol can be an alternative to benzodiazepines if they're ineffective or there's a contraindication to a benzodiazepine. But most of the time, we can wean the patient off of propofol, which is a pure sedative, in order to be able to use midazolam that has the anxiolytic properties and amnestic properties, which would be even better and more beneficial. So I find if we start bolusing the midazolam, start the drip, we're able to pretty easily get off of propofol in most cases. Steroids, in the past, these were just given routinely, sometimes before vent removals, but there's literature to support that is not needed routinely, but in certain cases of laryngeal edema or high risk of post-extubation stridor, it could be used. And there's a table to show some of the dosing that's been used to the right here on the slide. A cuff leak test can be performed by respiratory therapy, and that can give an idea about how their risk is of airway edema and stridor. So the literature does not support routine use of the steroids, but also anticholinergics for upper airway secretions. I mean, there's definitely a lot of people who are using it. We use it prophylactically. If there's evidence for it, it's more proactive than more of a reactive or therapeutic use. So anticholinergics help to prevent new secretions more than they do for clearing existing secretions. So if we're going to use it, let's just give it ahead of time. And one common medication used is glycopyrrolate 30 minutes prior to a vent removal. And you could schedule it every 4 hours after that if needed. I did want to mention I put a reference below of this article. It was basically a subcutaneous scopolamine that had been studied and scheduled 4 times a day could be effective for secretions. We don't have it on our formulary. I checked, so we're not using that, but just wanted you to know the Silence trial did show some benefit for that. So in case you're interested in looking at that further. Deep suctioning is also not recommended. So just here's a picture of the section of morphine for our order set, just to show how we can, at our institutions, add information for education purposes. So we all are going to be well-versed in how to manage symptoms in comfort care, but these order sets are often system-wide. Our order set is on all of our Coral Health hospitals across the entire state. So not only can we access it, our hospitalists or colleges, everyone can access it. So we're trying to provide education within the order set. So even just in the heading analgesics, we put things that you can use it for, like pain or dyspnea. Within the order set, and I don't know if you can see my cursor here. So under this note section of the morphine infusion, we write for any of our infusions that we consider titrating 8 hours after initiation or the last titration if symptoms are uncontrolled. For bolus dosing, we always have a lower and a higher dose. That way the nurses at bedside have a tool set. They have 2 different doses that they can use. And that helps when patients are in symptom crisis. It may take a minute to get hold of the provider to get the updated order. So at least we have 2 different doses that we start with our best guess. Our order set has a low one as a default, but we just put in whatever doses we want for that particular patient. And then within the note section, it talks about if the patient requires more than 2 of the lower dose, go to the higher dose. If they require more than 2 of the higher dose, then call to get an updated order. So packed with information as best as we can. So now I'd like to talk about the power hour and what that is. So this is something we developed at our institution because during that time of culture change, it was a big deal to have that additional support at bedside for nursing. They're like, how are we going to be able to spend time at the bedside and give boluses every 15 minutes for a symptom crisis or coming off BiPAP or high flow? And so we talked that this is about this being just as important as acute chest pain protocol or a code stroke. We just need the resources at the bedside. And if we do this well, the patient will be comfortable quickly and can maintain that. So that's one reason why we had that term power hour. And we're also using that time this hour is the time after even an acute symptom crisis outside of removal of respiratory support, or it's after removal of any type of respiratory support, such as coming off a vent, BiPAP, or high flow. And during this time, we're dose finding. We're trying to figure out how much of the opioid and benzodiazepine it took to ensure patient comfort. Because our team was thinking, there's got to be a better way than guessing where the bolus still should be or having half of that be the continuous infusion. We calculate for everything else we do for symptoms. We should have figure out a way. So what we did is we would take everything used in that hour that we could actually quickly get symptoms under control during that time. And we divide that by 4 for the opioids. And where we got 4 is that it takes most of our opioids can last up to 4 hours. So if we take that total amount that we were stacking doses and divide it by 4, that gives us an estimated hourly rate. For benzodiazepine, such as midazolam, which we prefer because of the short half-life, so we can titrate it more quickly, that we use the total amount in an hour divided by 2 because it has a shorter duration of action. And generally, these calculations work well. Sometimes if the benzodiazepine is overutilized, sometimes it's used maybe more than it needs to be for dyspnea because it's really the opioid that's the primary first-line agent. Sometimes that calculation could be too much if we are overutilizing it. So I always do the calculation and then see what seems best for the patient. So this is how we use that power hour. So during that time, like who's doing what? So the nurses are assessing symptoms and utilizing those bolus dose and PRN medications and reaching out if the doses are not effective. While the providers are really being available and ready to adjust those doses if needed to give just timely responses and updates to the orders. And then we adjust that opioid infusion once we finish the power hour to what is the set rate that will be effective for the patient. And we also have a lot of interdisciplinary support all throughout that time. So our goal is that comfort care is delivered in a way that's effective, safe, timely, and aligned with the patient and family goals. We know these are days that they will always remember. So next, I would like to talk about different processes for extubation. And even though we're wording in here is more about extubation, think of this also for coming off BiPAP or high flow. So there's one approach is a more immediate terminal extubation. This is when you give a pre-dose of an opioid and benzodiazepine and anticipate how much you may need. And then it's more immediate removal of the ET tube and extubation there. So, and then responding with additional boluses as needed. Where this may be more beneficial is patients who are already comfortable and unresponsive. Another time where it could be helpful is coming off of LVAD or ECMO, because once those have been stopped, there may not be a lot of circulation or blood flow. So the medications you give with that first dose may be the only that they actually get. So we usually do higher doses when we do that, those type of removals. So another option is a more titrated terminal weaning approach. And with this, their ventilatory support is more rapidly titrated off in a period of 10 to 30 minutes with a pre-treatment of an opioid and benzodiazepine, and then really decreasing by half of the settings, whether it's vent, BiPAP, or high flow. And then continuing every 10 minutes or so to continue to go down on those settings. And if a patient has symptoms are not controlled, you can always go back up on the settings and try to get symptoms under better control before going to that next step. During this application of that respiratory distress observation scale can be very helpful to determine when we should be bolusing. And also you could do a spontaneous breathing trial just to gauge the burden of symptoms after extubation. So in the last several years, there's been more research on this immediate versus titrated approach. And so I have Margaret Campbell's has done a lot of research in comfort care. And so her trial here just compared the two, and really, and there's been other studies as well. They're both great options. There are situations when one may be better than the other, but they're both considered acceptable evidence-based approaches. So when this titrated approach may be helpful is when there's a risk of airway obstructions. We really want to test and see how is the patient doing. It's also very helpful if patients are more alert and aware or symptomatic, because you can go more gradually and be able to better figure out the medications that they may need. So I recommend that everyone is comfortable in both approaches so that we can adjust based on what families' preferences are, what we may think could be most beneficial. All right, so let's talk about this scale that I've been talking about, the Respiratory Distress Observation Scale. So it's Margaret Campbell at Wayne State, so she's the local in Michigan, developed the scale in 2008. And she's had multiple studies on it since that time. So there's 8 observer-related parameters, including heart rate, respiratory rate, restlessness, paradoxical breathing pattern, accessory muscle use, and grunting at an expiration, nasal flaring, and a look of fear, which they have some examples of what a look of fear could be. And the key points of this is that the RDUS is the only known validated tool to objectively assess dyspnea in patients who can't self-report. It has good reliability. A score greater than or equal to 3 signifies a need to treat for palliation of respiratory distress with an opioid. It's not validated in children, neonates, in patients who are quadriplegic or bulbar ALS. Patients, it can be very helpful for that assessment of patients undergoing the withdrawal of any respiratory support. And I'll share a little bit how we have used it. Over time, we've incorporated into our electronic medical record and have a place where we can put an RDAS score. And we end up documenting it before and after the power hour. And if to even go a step further, what Margaret Campbell would recommend is that we actually, we could even document it after each bolus. And it shows why we gave it. Because there are times when nursing staff or other providers are asking, well, why did they need that? Or why are you giving so much or this medication? So it really shows why we're doing what we're doing and helps us pause and think about what we're treating too. Other assessment scales that may be used as part of this process is looking for signs of pain, and you can use the behavioral pain scale or the critical care observation tool as well. And I will say that I've seen more that the RDOS is starting to show up on boards, so it's something to remember as a tool that can be used. So communication is such a key aspect of this whole process. It starts with the patient and family when we're having shared decision-making and conversations. We're exploring their cultural, spiritual, and family traditions. That's what we do as part of our whole interdisciplinary team, and giving that anticipatory guidance. As far as the medical team, there's a lot of communication with the primary team, the timing of what's going on, making sure everyone's on board and has been part of that process. The bedside nurse and the hospice nurse often working together if a hospice team is involved. They're not in all cases, even though we think that's the best practice. So, and then during, even with our nurses, there's several steps of communication, including almost like a timeout before coming off respiratory support. Not everyone's the same, so we can't have a protocol. Everyone gets this dose and this medication. That would not be best practice. We see, are they opioid naive? How are they comfortable right now? There's so many questions that we talk about with our nurses before coming up with a plan. What are the family's hopes, and what does the patient want, if they can speak or have any input into what are they hoping for in this? So a lot goes into the planning, and I think a little timeout is helpful. And then 1 hour after the power hour or respiratory support, we touch base to talk about how much they use the medication so that we can really set the right rate for the infusion and boluses. And then 8 hours after that, we know we can further adjust their opioid infusion. So there may be that the nurses at least are calling the bedside, our hospice team is calling the bedside team to check in and looking at the chart, and then reaching out to our providers if we need to increase the infusion 8 hours later. And of course, good communication with the respiratory therapist, because we've had times where they've taken someone off of BiPAP or things before we've started our medications, and that does not go well. So I'm gonna read this case that we'll end up using as an example here. So Cindy is a 42-year-old woman with stage 4 lung adenocarcinoma and respiratory failure. She has 2 children, ages 7 and 13, and has previously discussed her wishes with her spouse and told them if she was ever in this type of situation, she would not want to remain on a ventilator, and it would be time to transition to comfort care. So he shared this with the medical team, and they start planning for comfort care transition. So Cindy has, her parents and 2 siblings have had a difficult time with this decision because they've been praying for a miracle. 1 sibling lives in California, the spouse, children, parents, and 1 sibling who lives locally plan to be at bedside at the time of the vent removal. So that's our case, and we know that we use an interdisciplinary team. We used to have a child life specialist on our adult team. We don't at the moment, but our social work team has really taken that piece on. So there's many people involved here, and I'm fortunate to have some of my colleagues here to talk more about their role during these type of situations. I'm going to start with Carissa. Get this video here.
Right. And I will say I have worked previously with the titration method that we had used in the past. And from the bedside perspective, this is much more measured and effective. Patients are comfortable in a shorter amount of time and a more measured amount of time. And it's much better to chart this as well as for documentation. When I'm charting charting a RDOS, like Dr. Rose said, in my comment section. What is the RDOS? What did I treat? What did I give? And you can look back and see why we gave the doses we gave. So much better from a bedside practice point of view as well. So this role, obviously, we recognize from the beginning that's a sacred role to be a part of end of life and preparing families. So there's a lot of preparation that goes into play. It's meeting the family, meeting the patient, whether it's been in their past. And in our case study, obviously, we have a young woman, a young family. So that heightens everybody's emotions right away. So we're entering the situation prepared for that. And then getting to know what has been her past symptom management needs. So we're prepared for where are we going to be jumping off from. A lot of people have been already on a lot of narcotics and benzos for different things. Some may not, but if they are, that we're taking that into consideration from where we're starting off from to prepare. And that means coordinate with our medical teams. You know, a lot of times they're also invested in this patient and they've spent a lot of time. And now we're at this point where we're handing off to maybe hospice team if we're involved to do this part of it, but they're still heavily involved, and we want to honor that and make sure that we're taking into their consideration what they've already invested into this patient and family. So a lot of the nursing role is going to be the hands-on, you know, medications, preparing the room, working with the bedside nurse that, hey, I've got this, you can do that, so that we're both utilizing our time wisely and the bedside nurse from hospice is actually going to be doing a lot of this education and prepping family that this is what you may be seeing happening. This is why you're doing it. You may see me doing a lot with pumps. I'm not going to give medication until I prepared you, preparing for the things that they may see as we're getting ready. And as we come off the support, preparing them that you may see this happen and this is why, and then getting that feel. Some patients and family want to know absolutely everything. Others, you get the feel that maybe giving them that option that you can step out of the room for this point. And that's okay. That I'll keep you aware of what's going on and let you know when it's maybe you're ready to come back into the room. But really kind of establishing that with the family that there's options here and we want to do what's best for you and for the patient. So doing a lot of that preparation with patients and families and education, working closely with that art respiratory therapy, that we're on the same time frame, that they're not going to be stuck somewhere when I'm getting close to extubation and I need them, that they know what we're working towards as well. And then the giving of medications. A lot of times I really appreciate my social worker being there because I'm watching the patient closely and going to be busy at pumps and giving doses and having that social work support to be watching family maybe a little more closely for their cues that I may not be watching as closely now because I'm really watching the patient. So we really, that's just such an important part of having the support to support both the patient and the family effectively. And then again, after we've done all these doses, communicating back with our hospice physician, this is what I've given in this power hour. This is what they've needed. This is what they look like now, so that we know where we're going to go from here. And then passing back to our bedside team, and our hospice team does check in. We'll either do a PRN visit later in the day or have one of our nurses call the bedside team and making sure they know to call us if they have more concerns about symptoms.
Thank you so much. Great. And now I'm going to have Carrie, one of our social workers, talk about the social work role. Carrie's
Here I am. Oh, can you hear me?
I can hear you. Yep. Now I can hear you.
Technical difficulties here. Going to piggyback off what Chris has said in regards to just the team approach and having both disciplines there at the same time, especially in this obviously very difficult situation. A young family is really hard. And I do want to just point out, just as providers, how important it is to recognize how you're reacting to the situation, because we're all human. And I think that we expect us, I don't know, everybody's different, but there's times I've been tearful in a room. And I think as long as you're not completely losing it, it's okay sometimes to be sad. It's a really difficult situation, especially this type of situation. And I think it's okay to recognize that you're going to have an emotional response to this, especially if you're a mom yourself and you have your own kids and that kind of thing. So just know we're there to do a job, but we're also, feeling things too. And just that self-care piece is so important in doing this kind of work. But just what Krista was saying, reading the room, assessing how each person's coping and reacting to the situation. Everybody's different in their own right. And it's okay. There's no right or wrong way to grieve. But like Krista said, she's going to be focusing on the patient more. I'm going to be reading the room and checking in with people, seeing how they're feeling. I always like to ask if they have any fears or worries, because just taking a moment to ask the question. I think some people are hesitant to even ask certain things because they think it's maybe a dumb question, or they're not they feel like they should know this. So I always like to make space to let them ask some questions. But as this is going on, just supporting the different people in the room, educating them on grief and bereavement support. And this is kind of all happening. There's no script. It just kind of unfolds as things go on. But letting them know about bereavement support that we can offer both with our team through hospice services, but also the supports in the community, especially for a young family with children. Elle's Place and Gilda's Club are wonderful resources in the community to provide additional grief support after a loss of a loved one for children. Letting parents know that, providing handouts on grief responses for developmental ages. The 7-year-old and the 13-year-old are probably going to grieve differently. And it's important to recognize those differences and what you maybe can do to support them. And providing like books and other types of resources that they can, reference later on when they're ready, because that's going to look different too, as far as when they're ready and when they're needing that support too. But we always let people, you can call us anytime down the road. We're always here. Again, we have that bereavement team to help support our patients and families with whatever they need, whether it's the parents needing some one-on-one support or just additional resources and things like, where do I go from here? I'm having trouble with this. So, and while in the room, just allowing space to reminisce and making time to let the children maybe process their mom's life and talking about how she was as a person and, giving honor to that. And I think that's important to do if they're open to it, of course. That's all going to be different depending on the child, on the parent, and those in the room. And another nuance to this is it sounds like some people might not be on board with this situation. And then that can make some very difficult interactions with the room. If someone's really angry that the person, the decision maker, is deciding this and they don't agree, that can be challenging in and of itself. So again, allowing people to have their own feelings about it, but keeping the room also a safe space for the patient. So sometimes we do have to get security involved if people get very upset, because we have to maintain the peace in the room too for the patient. So sometimes we are playing a little bit of, navigating that piece and getting the support to the people that need it if they're having a really hard time too. So yeah, I think that's it. Thank you.
Thank you.
I forgot the memory making.
Oh, go ahead.
Sorry, this one last thing, and our music therapist will touch more on this too, but we do offer fingerprinting, which I'll provide like just on a piece of paper. On Etsy, you can put fingerprints on all sorts of things. So it's kind of nice to have that little keepsake. Our volunteer services department also does memory bear making. We take clothing from the individual and make bears usually for children is who wants them. But that can be done as well, which can just be an added piece to that ongoing grief and helping support somebody later as a keepsake and a form of memory. Thank you.
Thanks, Gary. We'll move on to our chaplain, Dan.
Thank you. So in Cornwall, we're a large system, and so we're very fortunate to have a team of 3 chaplains who specialize in palliative and hospice. So that means we go between those 2 teams. And so in a case study like this, if we have been able to get to know someone like Cindy and her family, hopefully we've been able to investigate with them what is their belief system, how do they feel supported by it in their community, what a cultural background are they bringing to this kind of decision. And maybe even we've had a chance to talk to those family members who are struggling with the patient's wishes. As the case study mentions, miracle language is being used by the family. And so we want to explore that with them. Are they using that in a way that is, there's room for attention with maybe a miracle not happening, or is it being used in a forceful way where miracle is the only outcome that they can see as possible, and how are they coping? with arriving to a moment where others are choosing a different path and they're not seeing what they've prayed for. And so you're honoring the patient's wishes and beliefs while also supporting those who might be challenged by that and come from a different perspective. And as Carrie said, still holding that room as a place of peace and safety. And so when the hospice team then kind of gets a hold of me, I may have that history with the patient, having worked with them prior in palliative care, or I might be meeting them for the first time. And when it's more of a kind of a day of event and I'm a stranger to them in that moment, that's a very challenging thing for all of us as a team. And Carrie mentioned encouraging the family to really do that storytelling. That really does kind of bring the tension down and makes the room a sacred space where the patient can be celebrated and honored. It's less like a hospital moment. It's more of a holy moment. And the family can feel at least some comfort from that. And then hopefully too, we've had time to incorporate those community, cultural or religious leaders that are important to the patient and family for these moments as well. But also being a part of that team myself, just as our team has been saying, reading the room, seeing how people are coping, normalizing tearfulness, but also being the calm one in the room so that everyone feels like there's someone to lean on, someone to talk to, ask questions, even holding that tension of how just difficult this decision feels. It's a very singular event to do a palliative extubation. It's not this kind of natural waiting for occurrences to happen sometimes. So it's intense in an emotional way. So I love how our team is able to bring a variety of ways to support people and meet them where they're at in those kinds of moments. And for myself to kind of do my best to translate what is culturally, religiously, familially important of the patient and family to my medical teammates.
Great. Thank you so much. And then we have Kayla, our music therapist, next.
Thank you, Dr. Rowe. It's a pleasure being here. And I'm reminded this morning, hearing stories from my colleagues, how grateful I am to work with all of you and be able to provide compassionate care to our patients. But so I'll be speaking briefly about how music therapy could be supportive in a case study like the one we're speaking about this morning. So there's a couple of slides here at the beginning that just offer a little bit more information about music therapy as a field and what it is and what a music therapist's background is, just in case some of you have limited or perhaps no familiarity working with a music therapist as part of the palliative or hospice treatment team. But essentially, just highlighting it briefly, music therapy is just the evidence-based and clinical use of music-based intervention to support functional goals. So a lot of that's just information if you want to read more. And then on the next slide, there's a little bit of information about some of the evidence-based ways that music can be applied in a medical setting like this. But then moving into the case study, when we're looking at a situation like this, as it's been mentioned, where the patient is young, there's young children, and there's mixed emotions in the room. The music therapist, Dr. Rowe can go ahead and go to the next slide. I didn't say that. Thank you. Music therapists, if there's the opportunity to be at the bedside with the patient and family for procedural support throughout the ventilator removal process, to help maintain a calm environment, using music-based intervention to reduce potential distress that may arise, providing emotional support to the family through the process, as well as using music to divert attention or mask potentially aversive noises that may be coming from the removal of the ventilator to, again, help maintain a calm environment that's safe to hold whatever emotions may be present, which, as we've expressed, there may be, in this case study, mixed emotions present in the room. And closer to end of life, again, music therapy intervention can be supportive, continuing to entrain with the patient's breathing to reduce distress, help maintain that calm and comforting environment. And also, as some of my colleagues have mentioned, just making sure that the safe space is maintained to encourage reflection, using music to facilitate reminiscence and storytelling, including the entire family in the process, giving all family members that want to participate in expressing their grief or their joys, memories that may be coming up, or encouraging them to sing together as well. And then briefly speaking to therapeutic legacy projects, if the opportunity has been available to work with the patient throughout this disease process, songwriting may have been available through that process as a means of, again, expressing emotions present or telling their story, and then being able to record a song that's written, but also heartbeat recordings where a music therapist or another member of the team is able to use a digital stethoscope to record the patient's heartbeat. And then that heartbeat can be just, that recording can just be sent as is, or some patients may opt to have that heartbeat set to a song that's special to them. So say if the patient had identified, I want You Are My Sunshine to be a legacy recording, the music therapist could then take that heartbeat and use it as the primary beat to then record You Are My Sunshine over top of that with, guitar and voice or something like that. And then that recording can be either delivered as is to the family or placed into a bear or, another stuffed animal that could then be provided to the children in this situation. And that link there is just a little brief video that speaks more about the music therapist who created the heartbeat recording and what that process looks like.
Thank you so much. Well, yeah, big thank you to our interdisciplinary team members for just their roles and just, being part of this lecture today. And so please use the chat. We're keeping an eye on that. So if you have certain questions that you have for any of our team members, you can put them in there and we'll try to discuss those. So just going back to the case, let's see what we did. So we start thinking, even if we have the luxury of time, the day prior, we can start thinking about what can we maybe start taking off, like supplemental IV fluids and tube feedings that are not needed at that time and may increase the risk of terminal secretions. Also looking at their medications, we keep an eye on what are they on, what are we going to have to transition. If they're on propofol, we think of what is our transition plan. And so this patient was on already some low dose infusions, as you see. I won't go through all the things on here, but you can use this slide as a reference. There's a lot of preparation steps, things that you don't want to miss, such as, are they on a paralytic? Because we need to allow time for that to wear off. If they have an ICD, we need to deactivate it, either by the rep if we have time or a magnet if it's more urgent. And so those are some of the main things. The restraints, we don't want anyone to die in restraints. And there's some JCO or other type of things that are, there's citations if that actually happens. So we want to make sure someone is really freed from restraints and given medications for comfort. So all of those things are part of almost like a checklist that we actually have that embedded in our comfort care order set at the top as more things to think about as another teaching tool. And here I'll just have a table from this article that talks about the actual taking the ET tube out and the different steps of that process that a lot of times our respiratory therapist does this in conjunction with our hospice nurse at bedside. So you can look into that further too. So our case, the patient had been receiving some intermittent morphine boluses of 4 milligrams. And so we thought, well, if we're coming off of a vent, we're going to do more than was just the dose that was comfortable on the vent. So oftentimes I just double that, or commonly my starting doses are anywhere around 6 to 10 of morphine prior to coming off a vent if I'm doing an immediate extubation. But again, just depends on the patient. So in this case, the patient was given 8 milligram bolus prior to extubation with a linked order. We want something higher to go to. So I had a dose of 12, so 50% higher, every 10 minutes as needed. And midazolam, we did 4 milligram bolus with a linked order of 4 or 6 milligram boluses every 10 minutes as needed. And so this is sort of how we do the power hour. We figure out how we keep track of how our nurses are keeping track of what the patient was given. So this patient was given 2 doses of the 8 milligram of morphine, 2 doses of the 12 milligrams for a total of 40 milligrams. So if we use our 40 milligrams divided by 4, that gives us an estimated rate of 10 milligrams an hour that is that we should have the drip at. But the patient's already been at a steady state of 2 milligrams an hour. And so we wanted to add that 10 to, add it to that prior dose. So the new morphine rate would be 12 milligrams an hour for this particular patient. And then I know these seem like high doses, but these are actual cases and amounts that we have to use at some time. So the bolus dose, the 12 was really working, and there was a concern that the patient may need a higher dose if needed. And so we then had 12 as the lower dose and a 16 as a higher dose if needed. Sometimes patients are very comfortable and we think, we probably will go still between that maybe 8 to 12 and just keep it like that. So it's just really depending on how the patient's looking in a situation. But if we had just started that morphine infusion right before the vent removal, then we wouldn't really count that 2 milligrams an hour because they're not really feeling that. It's not reached steady state. So then I would have just gone with 10 milligrams an hour. So for the benzodiazepine, the total amount used in that hour was 16 milligrams. So our estimate is divided by 2 and also asked, does that make sense? Does it seem too much or too little? And we ended up, and the patient was already on 2 milligrams at a steady state. So we added the 8 milligrams an hour to that for a total of 10 milligrams an hour. And then the bolus doses were also increased because there was some concern that things could ramp up further. So a new bolus linked order of 6 or 10 milligrams every 10 minutes as needed. And just to go back here, that conversion tip of a 0.5 milligram of lorazepam is equal to 1 milligram of midazolam if you're trying to do calculations and figure out what dose of midazolam to use. So once we reset those drips to calculated based on what the patient showed us they needed, so it's not a guess. Again, this is just the way we do it, so it's an option. But this has been very effective. We find that once we have that calculated rate, patients are very comfortable. We're not making a lot of adjustments in these next hours. When it's 8 hours after, if they're still using a lot of boluses, then we will increase the infusion, based on how much they used. And we also can increase the boluses throughout that time at any point if needed. And the percentage increased is based on the severity of symptoms, 25, 50, or 100% based on that severity. And then again, when that 8 hours hits, then we may be talking about increasing the infusions. So I think we have a little bit of time. I'll just go through key highlights of a second case, and then we can go through any questions. So this is a different case where 75-year-old Jose has a diastolic congestive heart failure, is on BiPAP, cardiorenal syndrome, GFR of 25. So he had been by the primary team on some morphine as needed. So we thought maybe we'd do some fentanyl because he may be with us for some time, depending on how this goes too. So for him, the decision again made for fentanyl. For this patient, he's on a general floor. It takes a lot more coordination on our floors. And the way our pumps work, it's best to have an infusion going even at a really low rate so the nurses can push a bolus button on the pump and it gives them a bolus rather than drawing it up, wasting all those things that took a lot of time. So part of our process 7 years ago was making it very efficient for the nurses to be able to give boluses quickly and easily. So we'll pick a low dose, especially if someone's opioid naive. The lowest our fentanyl infusions can run is 10 mics per hour. So we have that running. So really we can bolus our opioid from the pump. And then we'll calculate after an hour what we really need to set it to. And then for this patient, also, we worried about symptoms of agitation, anxiety with it. So we just started a midazolam infusion. Again, this is an actual case, actual dosing for an opioid naive 75-year-old male. And sometimes if patient's not expected to have a lot of symptoms, you may use just some PRN midazolam for the removal. The nice part about midazolam versus Ativan at a time of respiratory support removal is that it works quickly and you can give doses, pretty close together. But once you know what they've needed, then you can use the lorazepam that's longer acting or an infusion. So here are calculations. The patient used 175 micrograms of fentanyl. So we divide that by 4 and get 43. Sometimes you just again, this is an estimate. You just say, okay, we aired up and went to 50 for the infusion rate, and then adjusted the bolus dosing to 75 to 100. Midazolam, we used 4 milligrams total. So we divide that by 2, and that seemed about right for this patient. And so they were on an infusion rate of 2 milligrams an hour, and then the boluses of 2 to 4. So this, we realize how much someone who's even opioid naive and elderly may need coming off of BiPAP. And I feel like the more you do these removals of respiratory support, the more you can guess what that starting dose may be, just based on your experience. And that's, I guess, how I've gotten to the point where I choose my starting dose, and we're always adjusting from there to see if we need more or less. So some takeaway points. Think of your opioid infusions like a long-acting medication and wait till the steady state is reached before titrating. And having a linked order for your opioid and benzodiazepine, a lower and higher dose, will help really get those acute symptoms managed well. And just stressing the importance of the interdisciplinary team and how that is essential to exceptional experience for our patients and their families. And just consider incorporating this objective validated RDOS score into your practice. And then we have our contact information, so you can reach out to us with any questions. We'll have some time to discussion, and I also have after this some reference slides so you can see different articles that I used in this. Probably have more I could even add, but we'll have maybe a few minutes for some questions. And it could be for anyone on our team.
Hey, Gretchen, and actually this might be for the entire interdisciplinary team. It seems intuitive, but I'd love to know your experience. If you go back to your first slide, right, you had a pre-state, right, and then a current state, better state, best practice. And it seems like we have at minimum 2 things going on here, right? There's a medical or pathological, the patient is dying, right? There's the medical component of that. Also a very human, spiritual event as well. And how do you find your confidence as you formalize, let's just call it the math, right, of dialing up or dialing in the opiates? Do you find that your confidence and overall temperature goes down, thus creating space for those other things, the human spiritual aspect? I'm assuming before this would have happened less commonly with a lot more, let's just call it anxiety from our own selves. Has that improved about thus allowing for that space for chaplaincy, social work, music therapy?
Yes, I think what I'm hearing your question is having a process and protocols and calculations. We're more confident in basically our medical management and our estimation of what patients may need. And then I feel like I can more confidently say we're going to be able to get you comfortable, and they know it may not be a perfect ride, but especially when these immediate extubations, you're like, hope so, but we know we have tools. We know we're right there. We know we're giving boluses quickly. So I can confidently say within an hour, you're going to be comfortable. And if we didn't have all this protocol, it could be hours before someone's comfortable.
Without the protocol, it can go a lot of ways.
Say that they're going to have a good experience that I could not have said before.
As Carrie
never
was
set up
talking,
for it.
and I hope, Carrie, if you could comment, because again, a lot of the things you mentioned, again, the first thing, the medical piece, does that give you a lot more space and thus agency to intervene there in those positive ways?
Yeah, and I think Krista mentioned it. Her and I have been on the team for 17 plus years. So we were there when we used to have
go sideways.
Yes.
Yeah.
And it's not fun when it goes sideways. It's very hard. It's hard for the family. It's hard for the providers, for us, because that's the last thing you want to see, because that's the number one goal for everybody when we walk in the room, is that the patient dies peacefully, right? So when we're not doing that for them, it's really hard on all of us. And I will say, since Gretchen came and started like researching and doing all of these changes, it's been significant. I mean, we rarely have occurrence of like just,
You can't get comfortable.
yeah, I mean, it's rare. But now even when it does happen, I feel like, oh, we know what to do now, or we know how to adjust or address it. So I feel way more confident during vent withdrawals than I did in the past, for sure. I don't have the anxiety.
For like high flow removals and BiPAP removals where someone's wide awake.
Yeah.
They don't want to be on this anymore. We can just be more confident in giving them their options. Like, you don't have to be awake. And 9 times out of 10, they're like, I do not want to be awake. Or
No.
9.5 times out of 10. So we can just prepare them for their fears and make sure that like you do not have to be uncomfortable, and you won't be uncomfortable.
Mhm.
I feel like those are harder. They're harder.
Harder. And we do this, we don't have time to cover our home vent removal, and we do all of this in homes. And we apply that exact same philosophy, interdisciplinary support, power hour. It's the same. The staff know it. It's the lingo we use. We all know what that means. We're at the end
And
of
like
our
you're
power
saying,
hour.
it adds a level of confidence. I
Yeah.
can talk to you confidently about a planned process,
Mhm.
things
Yeah.
that we've established and done and prepared for in the past and do regularly.
Part of
Our
the reason
nurses already know what I'm going to say too, and I calculate, they've already done the calculation of what they think too a lot of times. So we just sort of match, what are you saying, you know?
Part of the reason I bring it up, I recently was talking to the parent of a patient we had, and their grief has been very, it's complicated grief, partially because they felt in the last hours with their child that it was, they didn't have a chance to say goodbye because of all they were, this was in home and a lot of things. And with this process, again, it would have been nice if they could have had that space for that spiritual, humanistic aspect of what was going on. So kudos to your whole team for this process and sharing with us.
Thank you for bringing that up as what that does. Like, we forget that does allow space for all these other things. If they're not in crisis, they can actually reflect and have that full time. So really, that's a great point.
Absolutely.
Any other questions, comments, or practice differences you wanted to share?
But when are you going to publish this as the
I
road?
know. Okay, this is my tribute to John Moeller told me last year, and I said I'd do it. I will do it. We're gonna figure out how to write it up. It's not my forte, but I will do it. Hold me.
Oh, David has a question.
I don't know how many of you in your experiences have noticed, the morphine toxicity syndrome, or what, I don't know what it's called. And obviously we shouldn't have to worry about it when you got fentanyl and other opioids to use, but I know we've been kind of hammered that in renal failure, you don't use morphine, and with good reason, but I'm just asking, do you care at end of life? I mean, can you use morphine, or you just say, no, don't, stay away from it? Because
Yeah.
I've asked a couple people, I've had different answers. I just wonder what people think about it.
Technically, if they're only going to live for a few hours or a day, it's fine. But I'd say sometimes people live longer than you expect, and that could add up. Or if you have high symptom needs. So if you're just using some PRN and they have just hours, it's fine. But a lot of times, if they're already on a fentanyl infusion in the ICU, we don't switch them to morphine. The kidneys are fine. We just keep them on what they're on. But I think I just try to think, how long do they have to live? I do think fentanyl has worked just as well as morphine. So I don't think if we don't have a preferred agent. I saw in some studies, they say that fentanyl and morphine have been more studied than hydromorphone. So it's just something to think about. But I think all opioids can be very effective for dyspnea.
And has anybody seen in their experience, I mean, hopefully not, but like, I'm just reading like hyperalgesia and myoclonus and all this. I mean, you have,
The morphine.
that's probably distressing. So,
So it's gonna be more in your patient with a
Right,
surviving
right.
syndrome or the
Worsen your symptoms. And one thing I hadn't brought up is Precedex, because there's just so much I could add as medication. Sometimes people are on that as an adjunct. I always like to have a benzodiazepine if possible, like a Versed infusion or midazolam, sorry. Though sometimes I also, in severe agitation, and there's certain circumstances where that is an adjunct that could be helpful, or if someone wants to be more awake and there's like BiPAP removals or high flow, that could be another adjunct you could use in addition to midazolam. Or with midazolam boluses. So absolutely, that's a great, a dexmedetomidine. Precedex is a great additional option that could be used as part of these processes.
in patients with survivorship, say at least days to weeks, maybe months, that rotating the methadone. So usually when I say it is more in chronic use of the high doses of morphine, thus rotating the methadone, but that's different than our conversation here.
yeah. And just for reference, in the case last week, I presented the midazolam was used for.
In the past, people were using lorazepam infusions, but as we know from the math and the pharmacology of it, you would have to wait over 24 hours to reach steady state. So we don't really want to use lorazepam infusions. So that changed our practice once we did that education here.
This is Ken Hansen. I've got a quick question. I know you're pushing palliative consults down to the ER. Are you bringing this protocol down there? If they're
Yes.
doing, okay.
Yes.
And is palliative medicine pretty much running it, or are you involving the ER staff? I was just curious.
Yes, so we have our palliative care team embedded in the ED from 10 to 6 p.m. And so if they're there, they will manage it. If they're not there and our hospice team is still in-house, then they will come down and be part of that process. And if not, I think that ED teams are more familiar with our processes. They use our order set. So then we give lectures. So I think that they're able to step in if it's midnight and we can't get a team there fast enough. But we try to not admit and do this. We'll just do it right there if that's what's best for the patient.
Okay, thanks.
Okay, well, thank you, Gretchen. Was a great discussion with that one.